So,
Okay.
okay, it's all yours, so you can start now.
Okay. So good afternoon. Can you the people who were in the last session? I think I recognize Nakagawa-san is here. But it looks like there are some fresh faces.
Oh, yeah.
Looks like,
Really?
yeah. Yeah. It looks like Akita-san is from the previous one, and Aokage-san is still here. But I'm not sure about Nagai-san and Urushtani-san
Mm.
and Nakahama-san maybe.
Okay. Can
So there are
you,
some
everybody put
fresh
in
faces.
this chat, what grade are you? Can you just write it down?
Please, if you don't mind, yeah, to write
Like
down.
medical student, first year, second year, third year, or resident, whatever.
Yeah.
Then Joel will know what kind of like a level of people
Oh,
participating.
okay. Hmm. So quite a few of you are more advanced in your training.
I
A
see.
few, a few are first years, but mostly more advanced. Okay, whichever, it's okay. Whatever it goes, that's okay. I don't mind. So let me pull up a whiteboard. Okay, so we're going to spend this time discussing about why we do physical examination. So we just spent the last, for those that were in the last session, we just spent that doing why do we take a history? And we didn't really finish that. But why do we take the physical exam at all? Because I mentioned in the last session we've got scans and data, and you can measure everything now. Why do you need to examine the patient? What's the purpose? So please tell me your thoughts, please. Any ideas? Okay, so from Ijima-san, it can be a clue to knowing what's happening with the patient. Yes. How? What kind of, what do you mean by clue? Is it just that you're hoping to come across something like, oh, there's something there? Or is it kind of like looking but not really knowing what you're looking for? Or are you searching for something? Have you ever thought about physical exam? Is it an active process or a passive process? What do you think? Let me write that. Let me write. It's active. Yes, from Ijima-san there. Shunya. Thank you. So active versus passive. Often, because I train junior doctors, so they just come out of medical training, and I train senior doctors as well, more senior doctors. And for many, I think their understanding of physical exam is either it's not important, it's kind of a bit of a joke, or they regard it as a passive process. And if they happen to find something, then that's a bonus. Whereas um, for those who know how to do it properly, it's an active process. You're actually searching for things related to the history. Okay, so physical exam should be an active process rather than a passive one. Now, as I mentioned, I'm going to use this um, abbreviation for some of my talk, and it means physical exam. I created that, PXEX. It's easy, like CTRX and ABPC for antibiotics. I created mine for physical exam, so PXEX. Okay, so PXEX, physical exam, is directly related to the history. They are like a hand and a glove. They go together. They are not separate. The only time they're separate is when you have the patient who's unconscious, who cannot speak to you. That's when you just physically examine the patient and you may find the diagnosis. Okay, so history is a natural progression onto the physical exam. They are related. So what you consider as a possible differentials, so differential diagnoses, Kanbetsu Shindan, you then go on a search for physical signs to support the DDX, differential diagnosis or diagnosis, whichever you're thinking about. Okay, you're actively searching. So it's interesting. I do a teaching session called and I called it this, the Sherlock Holmes Bedside Challenge. And you say, what the hell is that? So who's Sherlock Holmes? Do we have? Oh, he's gone, isn't he? He was in the last session. There was a guy here. There was a medical student who lived in Surrey, in England. I'm from England. I'm not from the United States. I'm from England. So England has Sherlock Holmes, not the real Sherlock Holmes because it was made up character. Sir Arthur Conan Doyle created Sherlock Holmes. So I do a Sherlock Holmes bedside challenge. So that means I become Sherlock Holmes at the bedside. Do you know what I do? I ask them to bring me the patient. And I say to them, I do not want to know the history. I don't want you to tell me. They said, what? You don't want to know the history? I said, no, I'll tell you the history. What? So I then do a head to toe physical exam and I try and find the physical signs and I put together the history and I put together their disease from just examining them. Mind you, they have to have chronic disease or an acute process that hasn't got better yet. And in some cases, not every case, some cases, I can tell them the past medical history and I can tell them their current diagnosis. And in some cases, I can tell them what symptoms they had, which led up to their illness. And that's because the physical exam, number one, relates to the history, has to. And it tells a story in itself. The physical exam actually tells a history on its own, but they are related. The physical exam and the history are like a hand and a glove together. So if you ever get to see the bedside challenge, it's really, really good fun. Really good fun. Okay. But I can't do it at the moment because of COVID-19. That's the big problem with COVID-19. Okay. So physical exam, as I mentioned, is a active process. Oh, that's wrong. Active process. Looking for physical signs to support what you're thinking from the history. Okay, they are not separate. It is not just a joke. You all have to do OSCE. Now, traditionally, that's been done between the 4th to the 5th year. And then it was finished. Now, as far as I'm aware, medical schools are making you do a second OSCE before graduation. Now, if medical schools are doing this, and it's been gradually phased in across Japan now, and I'm glad that it is, because it's very important. I had to do that as well. It means it's important. It's not a joke. Otherwise, they wouldn't get you to do it. It's not just Mickey Mouse. You have to do it because there's a good reason for it. The question is, why is it a good reason? Can anyone tell me? Why is it a good reason to do a physical exam? Why is it a good reason to do a physical? There we go. There's that abbreviation again, physical exam. Can someone tell me? Think of some good reasons, please. Masaya-san, your head is chopped off by your camera. It looks like your head's been chopped. Are you okay?
Okay.
Good. So can you tell me what is a good, well, why is it a good reason to do a physical exam?
No invasive.
Okay, yes, that can be helpful, non-invasive. But well, it depends how far you go, because if you do a rectal exam, that's invasive. Is there any other reason you can think of why it's good to do a physical exam? Anyway.
No need to preparation.
That's a good reason, yes, because hopefully you've got your stethoscope with you, so you don't need to prepare. That's good. Yoshida-san, どうですか?
You can get further insights about the symptoms they have that cannot just be known from the history taking.
Now that's a good point. Good. Very nice indeed. So I think what you're trying to say is you may find something that the patient didn't mention about, and then you say, oh, what about this? Have you got this symptom? And they say, oh, yes, doctor, I forgot to mention that. I think probably that's what you're referring to, in which case, excellent. That's really good. And I do that all the time. I find stuff they haven't mentioned, and then I ask them about it. That's good. Yes, thank you. Thank you. Ijima-san, what do you think?
It always crucial. From the clinical symptoms like
Yes.
murmur or heartbeat sounds is crucial vital sign, and it's an important notice to treat the patient quickly, and we can do that in quick.
Okay, thank you very much. Yes, yes. So, picking up certain physical signs can indeed be helpful very quickly. Good. Now let's ask. I asked our Kage-san earlier. I'm coming back to you though. What do you think of why is it a good reason to do a physical exam?
I thought someone said that patient might forgot to mention something, but then also
Yes.
patient wouldn't know what's important for
Mm.
doctors to
Yes.
tell. So you might be able to find it by touching, and also you can like gain trust from.
Yes. Great. Someone said it. Hey, great. Trust. Great. Thank you. Finally, yes. Whew. Okay, what about Nakahama-san? What do you think?
In medical interview, you can't ask us so much information. So from physical exam, you find someone they forget to talk. Maybe.
Okay, yes.
I think.
Yeah, that's right. It kind of goes back to, I think, what Ijima-san was saying, or Yoshida-san, one of the two, about finding signs and then asking more questions related to that.
Yeah.
And they may have forgotten to mention it. Good. Thank you. Now we have Satoshi-san. Urushitani-san でしょ? Oh, hello. Where's your background? What is that? Is that very technical? What do you if you unmute, because your microphone is muted.
Sorry,
Yes, thank you. No problem. So why do you think it's a good reason to do a physical exam?
I guess you could get an objective evaluation on the patient's situations or symptoms.
Yes, yes.
Because if you're just listening to the patient talking and taking patient history, then you only get to know what the patient feels, and
yes.
It's you can't always tell if those things are important or not by just listening to that.
Very good, very good. Thank you. What is the background there, by the way? You've got is that the Nautilus?
Inside of the Millennium Falcon from Star Wars.
That's
great.
What I would say. Looks great.
Yeah. Millennium Falcon. So you're a Star Wars fan, are you?
A big fan.
I like Star Wars. I also like Star Trek.
I've only seen the more recent films for Star Trek, but
they're
like
good.
those.
They're good. I almost used a Star Trek background on mine, but I decided not to today. Went for the Golden Gate Bridge. Okay, thank you. All right. So let me just write down what I think as well about why it's a good reason. First of all, as was said already, oops, let me just get rid of this. Trust. Some patients hate doctors. Let's be clear about that. They hate them because doctors give them bad news. Patients don't want to hear that they're sick or they're going to die. So they hate doctors. They may think that doctors are arrogant, and some are. Some are very arrogant and they shouldn't be. So it's a difficult situation. You've got a patient who's stressed out, worried, they see somebody in a white coat come towards them. And they also, in their mind, the doctor is higher than them, and that should never be the case. Doctors are not higher than patients at all. Humans are all equal. But in their minds, they may think, that doctor, I don't know what that doctor's going to say or do. I don't know. Can I trust this person? They're not a family member. How can I trust this person? They're a stranger to me, and they're only here to give me bad news. So the history of we discussed earlier on, that's the time to start gaining trust, but also physical exam. Now, I will tell you this, and again from personal experience within my own family in Japan and abroad, patients expect doctors to examine them, and they expect them to examine them well. And when they don't do that, they lose trust in the doctor. If the doctor doesn't examine them properly, they say, ugh, that doctor couldn't examine me. I don't trust him. I don't trust her. Whoa. Did you know that? Yeah. Here's the opposite. Not recently, but in the past, I've done teaching in other hospitals, and I've gone to see patients, and I've done a thorough physical exam. And some of them, guess what? They cry. Cry. Not crying because I've hurt them. Not crying because I upset them and said something bad. They're crying with joy. And they say, thank you, doctor. No one's ever examined me like that. Or they used to examine me like that, mukashi. And they don't do that anymore. And they're crying because of it. Now, what does that say? What it means is that doctors these days are not examining patients properly. And patients expect it because they want to trust the doctor, that the doctor is actually understanding them. So a lot of the physical exam is gaining trust. And if you can show that you're doing your examination correctly and you understand it, your patients will always trust you. And it doesn't matter about whether you do a CT scan or not. They'll say that doctor doesn't need to use the CT scanner. That doctor knows what they're doing. I trust that doctor more than I trust the scan. This is a reason why patients are so interested now. I must have a CT scan. I must have lots of data, because they don't trust their doctors. Have you ever considered why? Because I'm from abroad, so I got the outsider view of things, and I've been living behind the bamboo curtain for 15 years. I know what goes on. I can see both sides. So it's important not just to think what you're thinking, it's important to understand what the patient is thinking about you. What do they want? What do they expect? And they want to be able to trust you, because they're putting their life in your hands. And I've got a list of doctors who I would trust with my life, and I've got a long list of doctors who I would not trust with my life, because I know which are the good ones and which are the not so good ones, and I won't tell you who they are. Okay, so one of the very important reasons is trust. And that's going through this process of going from head to toe down the patient's body. Okay. Now, of course, we are trying to find physical signs. And that's to support the suspected diagnosis that we've thought about from the history. But we may find signs unrelated to the history. It may be something that the patient didn't know about or had no symptoms about. We may just find it without knowing about it. And that may give us more clues to ask more history. Okay. So there's various things to think about with the physical exam. And as I said, it is focused. Okay. Okay. So let's now move on, I think, and let's go into some. Let's now go to some basic things. Before we even start the physical examination, it's often good to know basic vital signs. So what vital signs are we thinking about? What do we want to know in terms of vital signs? What are vital signs? What are they? Can anyone tell me? Ijima-san, what are the vital signs? Can you tell me?
Body temperature, blood pressure, and pulse rate, and
Okay, anything else?
respiration rate.
Yes, good, good. And anything else?
Or
You're almost there.
color of the face or something.
Not really a vital sign. Depends on many factors about that.
Pulse, body pressure, temperatures, respiration rate. Sorry, it's my.
No, don't be sorry. No. This is not apologizing session. That's when you kill somebody, you apologize. No one's dead in this session.
That's 4 things is all I know.
Okay, that's good. That's 4 things that you know. That's great. There's a few more that we need to add to that list. Can anyone add to that?
If they have a clear state of mind.
Okay, so you're talking about conscious level. Okay, that can be included. Yep, good. Anything else?
Is pupil dilation counted?
Neurological exam, not a vital sign. Okay, so let me introduce you. I love mnemonics. Okay, mnemonics are a shorthand version of long amounts of information, and that's how I remember things, particularly at my age. As I start to forget lots of bits and bobs, the things start falling off, so I need to bolt them back on with mnemonics. So you'll understand when you get to my age. You'll say he was right, and it'll be too late then. So I want to introduce you to this mnemonic called, I wrote this mnemonic, by the way, it's my own original one, called throbs. So what does throbs stand for? Well, throbs, it means your heart beat. If you, for example, you take your pulse at your wrist, like this, it's every heartbeat, it throbs. Boom, 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 throbbing. So I made a mnemonic based upon that, so that you can remember the vital signs. So what does that stand for? T stands for temperature. Okay. You don't need to say body temperature. It's obvious. You're examining the patient's body, so you're just checking the temperature. H stands for heart rate. Okay. You're not checking the pulse rate, even though you are checking the pulse. Later on, you're going to be checking the heart rate at the apex. Pulse rate can underestimate the true heart rate, particularly if you have low blood pressure or a dysrhythmia called atrial fibrillation, can skip beats. So heart rate is more accurate. R stands for respiratory rate, something which is, or at least until recently, was not being taught at medical school. So most of the residents I spoke to, and I say, what's the vital signs? They all miss out the respiratory rate. And respiratory rate is a very important vital sign, particularly as it makes up a sign for sepsis, which is called Q-SOFA, otherwise called Quick Sequential Organ Failure Assessment, Q-SOFA. One of those elements is the respiratory rate. Other element is blood pressure, and the other one is conscious level. So respiratory rate is very important. O stands for O2, SATs, saturations, or you could say oximetry. It just means SpO2. Okay? Although in Japan everyone says SpO2, you go abroad, they'll say O2 SATs. Oximetry, pulse oximetry, same thing. So that's what the O stands for oxygen. B is blood pressure. And S is the one which everyone forgets every single time. No one ever gets it. And it's severity of pain. How many of you have ever thought about asking patients how severe their pain is? Now, I appreciate that none of you have yet qualified, but even qualified doctors into their second or third postgraduate year, I ask the same thing, and they have a blank look on their face because they're not asking the patients about pain. And because of the culture, I know what the culture's like, I've been here for a long time. The elderly particularly do not complain of pain because it's kind of like, I must have a stiff upper lip, I must be strong and not complain about the pain. And if I don't say it to the doctor, that's okay. And the doctor's not going to ask me, I'll be quiet about it. And if I show I've got pain, maybe I look weak. And I've been told that having some pain will be better, that I get better. That's absolute rubbish, the whole lot of it. Patients experience pain, you should be asking them. No one should be in pain. I'll tell you this story at the moment, a personal story. My wife's mother is suffering from cancer. She's got stage 4 cancer. And she's got metastases everywhere. And she's in pain. And the doctors who are dealing with her are not treating her properly. They're not addressing her pain properly. They don't care. Or at least it seems like they don't care. And this is one of the problems I see. And that's why I'm trying to teach you, before you even qualify, you need to think about patients' symptoms, not just as that patients are a piece of meat on a going through a supermarket, going through the laser checker with the barcode. They're not just pieces of meat, they're human beings. And I mentioned earlier on in my history taking session, you've got to show that you're caring people. If you've come in to do medicine because you want to open a clinic and make lots of money, you're in it for the wrong reason. I went into medicine, and I'm still in medicine, because I care about helping people. And if you're in it to help people, you need to show that you care. And part of the caring is to ask them about pain and actually do something about it. And that's why I made this mnemonic a long time back now, to include pain, so that doctors ask about it. If you ever have a relative who has cancer or something that causes them pain, you will understand what I'm talking about. In time, you'll understand, because one of your family will eventually have some kind of pain, or you will. Then you'll understand. And I hope this changes you. I hope I can change you today just by introducing this mnemonic, throbs. But mark my words, you may not understand what I'm talking about for the next 5 years, maybe 10 years, but eventually you will. And then you'll click and say, ah, he was right. I hope it doesn't take that long. And that's why I'm trying to teach you this today. So please ask about pain as a vital sign. And also in surgery. Pre-surgery, post-surgery, very important, because it helps you to understand the type of analgesia and the amount. Analgesia means pain relief. And sometimes that's opiates. There is something called patient, what's the term? It's kind of a patient-adjusted analgesia. They have a button they can press, and they can give themselves extra doses of opiates if the pain comes back. But they can't keep pressing it, because eventually it gets locked out. But they can give themselves extra shots of PCA, thank you. Patient-controlled analgesia.
Yeah.
Yes, thank you. Thank you very much. I haven't used it in a long time because I don't see it here. This is one of the problems. I don't see it. Certainly not in medical practice. I'm not sure about in surgical practice, though, because I don't get involved with surgery here. But yeah, patient-controlled analgesia. So you need to know when you should be giving patients opiates or not. And this is related to how severe their pain is. So if they have, let's say, 1 out of 10 pain, you're not going to give them opiates. You might give them acetaminophen, for example. Or maybe 3 out of 10, you'll go up to NSAIDs. But you get a jump of 5 out of 10, maybe a mild opiate. And then let's say like it's 9 out of 10, you're going for the morphine. Okay, so it goes up in strength depending upon the severity of their pain. But that it's not just based upon the symptom. You need to understand what could be the cause, because they may not necessarily be telling you the truth, particularly if they're drug addicts. So you need to be very careful about that. And that's where the physical comes in as well. Okay, so as a side point, usually history and physical exam, they go together. They are usually, the history and the physical match. So they match. All right. However, there are occasions where the history and the physical, they don't match. So sometimes the patient may be complaining of severe abdominal pain of sudden onset, and you examine their abdomen and they don't have many signs. You say, "Ah, it's just constipation. It's okay, you can go home." Wrong. Wrong. That could be, for example, a obstruction of a blood vessel in the abdomen. It may be ischemia that they've got, early ischemia. So you need to be very, very careful about the history and the physical. This comes with experience and having good teachers to teach you these things, good surgical teachers, good medical teachers, reading, but seeing patients is really important. Okay, so that's the vital signs, a very, very important thing to remember. So please try and remember throbs. Okay, please remember this. It will help you. Okay. Does anyone have any questions about vital signs? Any questions at all? Okay, so let's now move on. So what would be the next step in the physical exam? What's after knowing the vital signs? Can anyone tell me? Do we just jump on the patient? Just launch onto the patient with our stethoscope, finish off the physical in 2 seconds? What do we do?
I think maybe observation.
Yes! Who said that? Who said that? Who said observation? Identify yourself, please. Who said that? Very good comment. Was it?
My name is Shunya.
Yes, very good. Excellent indeed. So observation, looking at the patient from the end of the bed. Observation, or general inspection is the other term. So observation or general inspection. Sometimes you can make the diagnosis just by looking. You don't even need to touch the patient. You can look and say, "Ah, I know what that diagnosis is," because you've stood back and you've taken in the whole view of the patient. Now, let me just ask you, have you ever been to an art gallery or an art museum? Have you ever been? Please raise your hands if you've ever been to an art gallery. Okay. Keep your hands up. Yeah. Who actually likes to look at art? Does anyone like to actually look at art? Few people. Yes. So it looks like Emmy's-san definitely likes to look at art. Good. Now, as you may say, what's that got to do with medicine? What's that got to do with medicine? That's art. Medicine is a science. Is it? Partially, yes, but it's actually a mixture of science and art together. They're mixed. Yeah, they're mixed. So what's that got to do with looking at patients? Have any of you been to France to see the Mona Lisa? How big's the Mona Lisa? Is it this big painting? It's tiny, this tiny little thing. And everyone's looking like that. And they can't get too close because it's behind glass, as far as I remember. So it's like, oh my goodness. Or you've got these massive paintings as well there in the same museum. You walk through the galleries. So the way that I teach about how to think about a patient is to start off as if you're looking at a big painting. Okay? Imagine you're looking at this massive painting. You're not going to go up to the painting like this, are you? Oh, look. You don't jump on the painting. You stand back, don't you? You want to look at the whole picture. Yeah? Yeah, you want to see, you know, there's the sea and there's the sun coming up over Hawaii. Like so, and then there's a few. I can't draw palms. I'm trying to copy in the background of Dr. Matthew here. You know, drawing. It looks awful, doesn't it? That's not a palm tree. It looks like a cauliflower. Okay. And then maybe you've got a house or something. I don't know. Very rudimentary drawing. I'm like a child, aren't I? Okay. It's a bit close to the sea, though, isn't it? With the global warming, it's going to get taken away over the sand. What do you think? Yeah. Okay. So you're in a museum. You're not just going to go up and say, I want to look at that speck of sand down there. Even if that's what you're looking for, you're not going to just go up to it. You want to look at the whole picture to understand what the whole picture is. And then you gradually move in. And then you may well focus on this, and it may well be, oh, there's a speck of sand. Okay, great. Yippee. Hooray. Whatever. So this is how you look at a patient. You look at them as a whole person. Even if you're a specialist, I'm a junkanki. I only look at the heart. Rubbish. Absolute rubbish. If you ever think that becoming a specialist means that you just look at one thing, you're fooling yourself. Absolutely fooling yourself. You're looking at the whole patient. You should do. Okay? Just by saying I'm a specialist is an excuse. It's an excuse to lose the skills that you should have had in the first place. Or it means you never had the skill in the first place and you're just trying to specialize in one area and you know nothing else. Either way, it's bad. And doctors shouldn't be like that. So you should try and think of yourself as a generalist with a specialist mind. You should always be a generalist. So looking at the patient is looking at them generally, and you're then specializing in this certain area, but you've looked at the whole patient in the beginning. Okay, so try and look at your patient's general inspection. You may be able to diagnose them just by looking. So what kind of diseases could you diagnose just by looking? Diseases by inspection. Can you tell me, do you know any diseases you can diagnose just by looking? Let's just brainstorm. What do you think?
Lyme disease.
Sorry, which one?
Lyme disease.
Lyme disease. So, okay, how you may be right, but I want you to tell me how you're right.
I noticed some erythematose or lush on their skin.
Yes, very good. So it's called erythema. It changed its name a few years ago. It used to be called erythema chronicum migrans, but now it's just called erythema migrans. So I'm going to write in the old name because you may come across that, migrans. And that's a rash that comes up from the infection, which is now called Lyme disease. It's called Lyme disease because it was first of all described in the town of Lyme, Lyme, in the United States. It's not Lime, the lime you put in your Corona beer. By the way, Corona beer is very nice. It's quite apt to be drinking it during the coronavirus outbreak. Bottle of Corona with some lime. If you like that, try it out. It's nice. Anyway, getting back on track. Getting back on track, yes. Where was I? So yes, Lyme disease. Okay. Good. What other diseases can we just say, it's that disease. I can look at it from the bedside.
Heart failure.
Oh, that's a difficult one. What signs would you just by looking, without touching the patient, how could you know it's heart failure? Because that's a fluid overload state, isn't it? And there's other ones like nephrotic syndrome and chronic liver disease. How can you separate those ones out just by looking?
How they sit, like position.
Well, it might be helpful, but I'm not sure that it's diagnostic. That they say, that one's heart failure, that one. And that one's a liver disease one. You might be right, but you might not be. I'm thinking about ones that are absolutely certain. That's a simple case of. Boom. Heart failure to diagnose just by looking, observation, you might get it right, but it's not absolutely certain. I'll pop it down on the list though. You might be right in certain instances. Let's say congestive heart failure. Maybe. What else? Let me give you a clue. What about some Nibun-Pitsu diseases? Nibun-Pitsu. Endocrine.
Addison disease.
Okay, so what features of Addison disease can you say? That one's got Addison's disease.
It's hyperpigmentation. Hyperpigmentation is
where
for me.
Where exactly? Because you can get hyperpigmentation from other diseases, or just going out in the sunshine and getting a suntan. You get hyperpigmented that way. So how can you separate those and say, that one's a case of Addison's disease?
So, again, sorry, I don't know.
It's okay.
I think it's wrong. It's me.
No, you're not wrong, actually. You might be right. And you can look in the palms and you can look at the creases in the palms and they get hyperpigmented in Addison disease, and also the gums inside. On the gums where the teeth are, they become hyperpigmented as well. That's a clue. The nipples as well, male or female nipples, can also become hyperpigmented. So there are certain areas of the body that shouldn't be hyperpigmented and they become that, and that may be a clue. Addison disease is in some cases related to autoimmune disease, and autoimmune diseases tend to go together. So sometimes you can develop depigmentation from a autoimmune destruction of melanocytes, the pigmenting cells in the skin, and they can occur at the same time. So you can get hyperpigmentation and depigmentation in the same patient, and that's a big clue. That's a bit more technical though. Okay, so some endocrine diseases, and you could say maybe Addison. Good. Addison disease. What other endocrine diseases could you say, that might be a case of? Boom. For example. I'm a man. Are you a woman? Sorry?
I mean, and multiple endocrine neoplasm.
Good luck with that one. I'm an endocrinologist by training, and that's a difficult one to say, that one's got men's type 1 just by looking. Difficult. Try and keep it simple. Or I always say, try and distill everything down to its most basic thing, but not simpler than that, but to the basic thing that you can say, that's a case of. But MEN is a bit more difficult, I think. But try and think about some more simpler endocrine diseases just by looking.
Acromegaly?
Yes, good. So acromegaly from excessive amount of growth hormone. So they may be very tall, for example. That may be because they've got gigantism, and they're very tall because they grow before their epiphyses fuse. So they end up being very tall. Have you ever seen James Bond? You ever seen, maybe before your time, most of you, not us older people in the group, but the younger ones. Who's seen James Bond? You give me a thumbs up. James Bond, 007. Dun, 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 dun. Come on, you must have seen James Bond. Look, there's a film called Moonraker. I'll write it down. This is homework. Moonraker. Okay, this was with Roger Moore. Roger Moore. He's dead now, I'm afraid. And did you hear about Sean Connery? Sorry?
I was going to say, does that make me old if I know that movie? Because I know that movie.
That makes you probably as old as me.
Daniel Craig right now, so I bet they know Daniel Craig.
Oh yes, Daniel Craig. He's actually quite a good Bond. Actually, I didn't like him at the beginning because he got hurt. Bond's not supposed to get hurt. Bond is supposed to be invincible, but Daniel Craig changed it and he got bruised up. And also Sean Connery just died. What was it? A week ago, ish. That's a shame.
Like that, yeah.
He was my favorite Bond. Money Penny.
My
Anyway.
favorite Daniel Craig, but
Yeah, but he's good, Daniel Craig. Yeah, but let's get back on track about this though, because Moonraker with Roger Moore, there was a character in that film called Jaws. Not Jaws like in the film with the shark. And that's another film you need to go and see as well. That was good, Jaws. But there was this character called Jaws, and he had gigantism, and he had these massive silver teeth that he was killing people with, biting their neck. But he had gigantism. So that meant that he had a pituitary tumor secreting growth hormone before his epiphyses closed, and he ended up being this massive guy. And he died a few years back as well. I always remember the people that die. I don't know why. I don't remember the ones that were alive. Oh, that one died. Any of you ever think about that? Go, oh, he's dead, that one.
it's an occupational hazard.
It is, isn't it? It's like, oh, that one's died. And also what they died from. It's like I'm a death register. Ah, that one died of that disease. It's terrible, isn't it? Anyway. Sorry. The humor coming out this afternoon is immense. Okay, so acromegaly. Now, if you develop growth hormone secretion after your epiphyses close, that's the long bones close, then you end up getting other bits that change. So you end up getting a big kind of thick forehead, your nose continues to grow, your ears continue to grow, and your jaw continues to grow, and your teeth separate. You've got lots of spaces between your teeth. Your hands continue to grow, and your feet do. So, but it's can be very easy to tell just by looking. So acromegaly is something that you can sometimes diagnose, but it's rare as hen's teeth. It's rare. Can you tell me a much more common endocrine condition that you can diagnose just by looking?
I don't know if this is an endocrine disease, but
That's two people talking at the same time.
Oh, sorry.
Immense.
Sorry, I didn't notice. Okay, the other person,
Yeah.
please.
Oh no, you go ahead. You go ahead.
I know. Let's do Junkenpoi. whoever wants to speak first, please go ahead.
What about jaundice?
Jaundice, that would be under metabolic for some reason. That would be under. I would put that under metabolic. Now that is a sign, but it doesn't tell you the disease. It does tell you that there may be a hematologic or a hepatobiliary problem, but it's not specific to either. But I'm talking about, I mean, it's certainly a sign, but it's not a diagnosis in itself. It would be jaundice secondary to something.
I see.
But I'm going to write it up on the list so we don't forget to talk about it. Okay, so we can certainly say a patient is jaundiced by looking, definitely. But endocrine-wise, so I think the other person that jumped in, come back, whoever you are.
Yes, that's me.
Yes, please.
I was trying to say Cushing syndrome.
Yes, Cushing's.
And
Now,
also
Cushing's.
Nagisa-san. There's
Sorry?
another Nagisa-san.
Oh, please, yes. Keep it coming.
Graves disease.
Yes, Graves, otherwise called Basadalbio. Very good. Excellent. Okay.
Iijima-san
Yes.
wanted to say something, right?
すいません、独り言が入ってました。申し訳ないです。
Okay. Good. So yeah, so Cushing's disease, these patients, they kind of have a moon face, what's called a dorsocervical fat pad or buffalo hump, which is a bit rude to say. And they get what's called central obesity, and they get purple striae, which are these purple discolorations of the abdomen because the planes of fascia have ripped apart because of the steroids, making everything weak, and the blood vessels rupture and they bleed. So it's very clear to say, this patient may have Cushing's syndrome, or if they've not been on steroids, they may have Cushing disease. Okay, so it's whether they're on steroids or not. Usually it's because they're on steroids, frequently on steroids. And Graves' disease, very well, not always can you tell, but in advanced cases, you can certainly tell. They have exophthalmos, sweating, and they may have a very large neck. So it may be obvious from those things. So just by standing back and looking, you may say, that's that disease. That's easy. Because you know the phenotype of that disease. Other things that you might be able to tell are occasionally neurological disease. So what neurological disease might you be able to tell just by looking?
Parkinson's.
Yes, very good. So Parkinson's disease. So what features that might make you think about Parkinson's disease just by looking?
I guess like a mask-like featureless face.
Yes, mask-like featureless face. Yes. And
shivering. I'm not sure.
Tremor.
Tremor. Sorry.
No, don't say sorry.
Oh yeah.
Only if you killed someone. Okay. Make sure. What kind of tremor?
So the kind that happens when you're not moving.
Yes, it's a resting tremor.
Whoops.
Resting tremor. That's it. And particularly what's called a pill rolling tremor. So what you say? What the hell is a pill rolling tremor? When they used to make pills in the good old days, before I was even conceived, and even before Dr. Machi was conceived, they used to make pills and they used to roll them in their fingers like this. But they used to pick up the whatever the drug was and they rolled it like that. So that's the same manifestation that you see in some patients, not all patients, but some patients with Parkinson's disease. They have pill rolling tremor at rest. And if they focus on it, they can stop it sometimes. But if they don't focus on it and you take their mind off it, it goes like this. And they look at it and it can get better or stop. Take the mind off of it, it starts going again. So you can tell sometimes. Any other features of Parkinson's that you can tell by just looking? Yes, gait. Very good. You kept quiet then. You didn't speak. You're normally very vocal. Please speak. Yeah, don't be shy. Very good. So yes, gait. And they may have a kind of shuffling, festinant gait. And they may have difficulty turning around. They may fall over. And they certainly have got problems with maintaining the center of gravity. Okay. So Parkinson's disease is a very good example, and it's a very common neurological disease. Can you think of any other diseases which are neurological that you can see? Yeah.
Bell's palsy.
Ah, excellent. So a seventh nerve palsy. And commonly it may be idiopathic. Used to be called idiopathic, but it's not. It's not idiopathic. It's immune. Okay. And it's because of reactivation of a herpes virus, herpes simplex. So it's immune, and this can produce the so-called Bell's palsy. Okay. But it's a immune seventh nerve palsy, which is a lower motor neuron palsy. Good. So you can tell because their face is drooping, sagging. Yeah. What else can you tell by just looking? Any other neurological diseases? What about stroke? Yeah.
This may be very rare, but
Go ahead.
for example, Tourette's syndrome. Or
you mean Tourette's?
Yeah.
Yes. It's not that rare. You typically see it in adolescents. So yes, you can tell. And they also have tics, and they start swearing. Have you ever seen somebody with Tourette's syndrome and they start? I won't say it on video,
No,
but
I
I've
just
seen it.
read it in a book.
Yeah, in real life, it's much more florid than in a book. And you go, oh my goodness me, and they start swearing. So yeah, so Tourette's. Okay, but much more common is, common garden stroke. We discussed it in the history taking. And if they've had a seizure, yes, that's obvious, that one. Yeah, definitely seizure. If they had a dense stroke, so a unilateral dense stroke, they're only moving one side of their body. So you'll see the hand move on one side or their leg move on the same side, but the other side's not moving. And you can sometimes diagnose a stroke just by saying, oh, they're not moving their other side. That's a stroke, isn't it? And then you look for the cause of the stroke. And so you're looking for the cause, but you've already diagnosed it just by observation. As somebody just mentioned, seizure, partial seizure, generalized seizure. Yeah, just by observation. That's an easy one to diagnose. Another one, maybe supranuclear palsy, or progressive, I should say, progressive supranuclear palsy. It's called PSP. And they have this surprised look all the time. Surprised the whole time. Okay, and you may say, they may have PSP, and they may have a Parkinsonian look to them. So they may have stiffness, difficulty moving, falling over. Typically, they fall backwards. And you may see as they walk into the room, they look surprised. I say, oh, is that PSP they've got? So just by using your skills of observation, you may be able to diagnose just by looking. And you may think it's strange or funny. I spend my entire time when I'm out in public just looking at people. I'm interested in people, of course, but I spend my time looking because I'm looking to see, oh, is this person normal? Is this person got something wrong with them? All the time. And I learn by just looking at people. That's what I do. Strange, isn't it? But I'm like that, you see. There you are. Okay. So that's the strength of observation. So we just spent like, I don't know, 20 minutes talking about that. So what comes after observation? Depends which country you learnt your medicine in. Because if you're in the USA, you start with the head and neck. Head, eyes, ears, nose, and throat. Okay, so that's called HEENT. It's HEENT, not heent. Heent, I hear all the time here. It's not a word. Okay. Head, eyes, ears, nose, and throat. HEENT. If you trained in the UK like I did, you don't start with that. You start with the hands. And you move up the arm to the head and neck and then back down the body again. Okay, so either way, whichever, if you like that way, head and neck, that's okay. I like the hands to go first because there's lots of signs in the hands that can help you diagnose disease before you get to the head and neck. Sometimes if you do the head and neck first, you forget to look at the hands, you've missed them. So I always start with the hands. Okay, whichever. But the hands then go up to the head and neck, and then down the body. Oops. Okay, so you don't miss out on those. And that includes checking the pulses in the hands. You should all be checking your patient's pulses, you know. You should all be checking the pulse on the wrists when you examine them. You want to know if they're alive, don't you? That's why you check the pulse. Okay, so why are we looking at hands? Let's just discuss about hands. I could talk to you about hands for quite a few hours, actually. So why are we examining hands in the physical examination? Can you think of any reason? Any ideas? Nakahama-san. Show me your hands, please. You're not under arrest. No, the other way. Don't say, no, don't shoot. Hantai desu. I want to look. There we go. So I want you to put up your nail to the camera, please. Just the nail. Okay. So you've got normal nail. That's normal. Okay. Your nails are normal. So say, thank you very much. So hang on. Why are you looking at nails? What's wrong with you, Dr. Branch? Why are you looking at patients' nails? Nails are actually very important, and they can help you sometimes make diagnosis. Now, can you tell me, or do you know any nail signs that might help you with making a diagnosis?
Hemorrhage from infectious endocarditis.
Very good. Okay, so let me draw this. So I'm as you could tell from earlier on, I'm not very good at art. I like looking at art, but I'm not an artist. Okay, so please forgive me and my poor artistry. Right, now we've got that out of the way. Let me draw in a finger. See, already started off bad. Okay. So let's imagine there's a nail. Everyone has a lunule, and there's, okay. So imagine, let me try, yeah, they're usually black. Imagine you've got these lines in the nail. And they're these tiny black lines usually, or purple, sometimes purple. These are called splinter hemorrhages. Splinter hemorrhages. Now, sometimes you will see these in patients who have an infection on the heart valve. So that's called infective endocarditis. Now, on their own, they're not very meaningful. I usually have one at any one time. Have I got any today? Yeah, I've got a tiny one there. I don't know if you can see it on my finger. Probably not. No, I've got a tiny one in my finger. I always have them because I'm typing. And I'm also doing percussion of patients. So I get them from doing percussion. So they can be from trauma. They can be from people who do lots of typing. People with vasculitis for other reasons. People who climb mountains. They can have these in their nails. It's not specific to Shinnai Makuen. But if you have a patient who has fever, who has a murmur, and you find these, this may help to support that idea of Shinnai Makuen. Okay, so splinter hemorrhages. I'm glad that at least one of you knows about splinter hemorrhages because they're really important to know about. Okay, good. Can you think of any other nail signs?
Spoon nail.
Okay, so spoon nails. Now, the actual real name is not spoon nails. Everyone knows it as spoon nails here, but no one knows the real name. The real name is called Koilonychia. Koilonychia. That's the real name. So, again, I apologize for my drawing. So I'm going to try and draw the side view. Just go back. Now it is kind of like that. That's the side view. That's the side view of a finger. And the nail dips here. So that's why it looks like a spoon. Because you can actually put it in the water and it will carry water. You shouldn't do that, of course, as you know. And you can get that on your fingers, you can get it on the feet. So what does that suggest if you have koilonychia? What does it mean? Who mentioned koilonychia, or the spoon nails? Who mentioned that?
Iron deficiency.
Okay, so it can be associated with iron deficiency. Do you know any other causes?
Pulmonary carcinoma.
Which one?
Pulmonary carcinoma.
So what, lung cancer?
Yeah.
No, that's a different kind of nail sign for that. Different kind. So let me tell you some of the other causes, and it may shock you. There are quite a number of other causes. Okay, so it can be normal. It can be normal. A good friend of mine in Japan, he's a cardiologist, and I was going to teach at his hospital, and he came and picked me up at the station. And so I got in his car, I looked down at his hand, because, you know, I look at people, you see, and I saw, oh my God, he's got spoon nails. So I looked at him, I said, are you okay? You've got spoon nails. Oh, he said, oh, I've had this all my life. So it, you know, it can be normal, and particularly in children below the age of 2, they can have this normally. It's not abnormal in children, but you can have it in thyroid disease. Trauma. It can be related to your job, so it may be occupational related. Also Raynaud's, something you may not have heard of yet. You'll learn about this. A Raynaud's phenomenon. What else? Psoriasis. That's called Hifkensen. Psoriasis. SLE, which is an autoimmune disease. Baidoku, which is called syphilis in English. Or it maybe it was called idiopathic. Means we don't know. Whenever in medicine we don't know something, we say it's idiopathic. What? Oh, you've got it's idiopathic. So what's the cause of it? Means I don't know. It's a doctor's way of saying I don't know. Idiopathic. Okay. There's always a cause of everything. So at this point, sometimes we just don't know yet. So we say idiopathic. Or the other term for it is cryptogenic. Sounds really nice. Oh, it's cryptogenic. But doctor, what's the cause of cryptogenic? Idiopathic? What does that mean? I don't know. Better to say I don't know to patients, really, rather than make up some rubbishy term that's used in medicine. Idiopathic or cryptogenic. Just say I don't know. We don't know yet. Okay. So if you have a look here, there's quite a number of causes of this sign, which means it's a bad sign. It doesn't help us make a diagnosis unless the patient has other signs to add together. So, for example, they may have pallor of their eyes. Okay, so their conjunctiva are pale. They may have an inflamed tongue called glossitis. So it's smooth, it's red. They may have a painful tongue. They may have the corners of the mouth, which are red and painful and bleeding, called angular cheilitis. Yeah. So those may be just a few additional clues. And if you find those clues and you find the spoon nails, you say, ah, this may be iron deficiency. So what I'm trying to get at is one sign may sometimes diagnose, but usually it's a combination of signs put together that gives you the diagnosis in physical exam. Okay, so if you were to be having a patient who's got symptoms of anemia, then you look for signs and you find them on the patient which are consistent with this idea of iron deficiency. You may diagnose it just by physical exam and history. So that's an important sign occasionally, but usually not. Can you think of any other nail signs? Somebody said about lung cancer. Who said about lung cancer? Was it Ijima-san? It was you, wasn't it? I didn't even need to look. I knew it was you. Okay, so that's good. Keep it coming. I like people to talk. I like people to talk. So lung cancer. What nail sign does lung cancer produce? Can anyone tell me?
Clubbing.
Clubbing. Yes, Batsuyubi. So that's called digital clubbing. Okay. So digital clubbing. Let me just draw a picture again. Please forgive my bad drawing. I'm overdoing it here, by the way. It doesn't normally look quite as florid as this. Okay, so the end of the finger is red. It's swollen. It looks like a drumstick, you know, for doing the drums, playing the drums. It looks like a drumstick. Not a drumstick like a chicken drumstick. Not the ones you eat, the ones that you play with the drums. And the nail is significantly curved, like so. There are other features which I'm not going to go into today, but one thing that I will go into is if you put your fingers together like this, you should have, it's difficult on here, you should, oh, there you go. You can see between my fingers, there's a diamond shape there. So if you were to put the fingers together like so, normally, there's a diamond shape for normal fingers here. This area here is a diamond shape. Okay, this is called Shamroth. Shamroth sign. So this is normal. You should all have that. If you put your index fingers together, like so, that should be a diamond shape between your fingers. If you have clubbing, you put the fingers together, they make what I term, it's what I've termed an inverted V sign. Inverted V sign. It's not in the books about the inverted V sign, that's my term. If you find that, that means it's positive for clubbing. Okay. So, for example, you may have a patient who's been losing weight. They've lost 5 kilograms in weight. They have a cough. They have a voice change. They're coughing up blood. And they're a smoker. And you find clubbing. Cancer, isn't it? You can sometimes shortcut the diagnosis. Say, oh, he's got symptoms that sound like cancer. He's got clubbing. And clubbing is associated with lung cancer. But there are lots of causes of clubbing. There's lots of causes. And I'm not going to go into all of those because there are so many. But under certain instances, clubbing can be very helpful to push you towards a diagnosis. Okay. Can you think of any other nail signs that might be helpful?
Hello.
Yes.
Okay, I think
Hi.
sometimes we can see like white nail, like tarry nail, for somebody has a liver disease
Ah.
or alcohol drinker.
Yeah. That's called leukonychia. Leukonychia. So that means that the entire nail is white. And this is related to the patient having prolonged low protein levels. So, leuco means white, and nichia means nail. Put them together, leukonychia, which equals white nail. That's all it means. It's just a description. But of course, doctors like to say these lovely technical words. You've got leukonychia. So the patient doesn't understand. Oh, I've got leukonychia, doctor. Oh, yes, you do. But what does it mean, doctor? It means you've got white nails. Oh, well, couldn't you just say white nails? No, because I want to confuse you by saying leukonychia. Same as idiopathic and cryptogenic. It's meaningless. Okay. But one of the causes may be prolonged low protein levels, which can be with chronic liver disease, as an example. So good. But it's very rare. I've only ever seen a few cases of it. It's very rare. Any other things? What about if I was to say, can you diagnose chronic renal failure by looking at the nails? Is that possible? What do you think? Any idea?
Refilling time.
Nope, that won't help you. Good thought, though. Anyone else have any idea about how you could diagnose chronic renal failure by looking at people's nails? Are you crazy? Is that possible? Dr. Branch is crazy. Actually, I'm not. Only partly crazy. Part-time. Lindsay nails. So Lindsay nails are also called half and half nails. Okay, so let me try and draw on that. Oh, that looks like a thumb. Oh, okay. Thumb. Oh, try this again. Okay. If you draw a line halfway across the nail, and then you color this. Oh, wrong one. Color this in like so. I'm afraid I can't do different kinds of colors here because Zoom, for some reason, won't give me a full palette of colors. So I can't be an artist today. But just imagine that this top part is kind of kind of a pinky purple. Pinky purple. Don't know what you'd call that otherwise. Pinky purple. Anyway, here is white. Ish. That's a half and half nail. If you look at your own thumb, that's not a good example. Well, okay, look at your own index finger. That bottom part should be very small, half moon. It's called a lunule. The rest of it should be pink. But in this instance, half of it's become white and the top half is left as pink. So that's why it's called half and half. And this is found in patients who have chronic renal failure or they've got HIV/AIDS. Okay. But frequently, if you look at your elderly patients in this country, the cause is almost entirely going to be from chronic renal failure if you find Lindsay nails. If you were to find this on maybe a younger patient, depends on their sexual history, but they might occasionally have HIV/AIDS. Okay, but frequently it's chronic renal failure, something renal related. Okay, so what I'm trying to go through here is just by looking at hands, you may start to pick up about serious, sometimes serious, systemic disease. Okay, so let's just go back over this. Here in the nails, we've got a potential for an infection on the heart by just looking for these. Here, if you've got these together, you might have iron deficiency. It may be because the patient's got a colon cancer and requires expert surgery to remove the carcinoma. You may have to call in the surgeons. Okay, so an overlap between medical and surgical. Here, maybe the patient's got cough and weight loss and hemoptysis, and they've got clubbing. Maybe they've got an abnormal physical exam of their lungs and an x-ray shows a mass. Again, you may have to call in the surgeons or call in the oncologists. They've got a lung carcinoma. Here, you've got a patient who's got half and half nails. They may have unknown severe renal failure, and they may have to end up going on to dialysis soon. So you're picking up serious systemic diseases just by looking at nails. It only takes a second just to look at the nails, and you may shortcut your diagnosis. Okay, so this is what I'm trying to get at, is observation. It's the key to diagnosis by physical exam, is observation. Observation, from general observation to more precise, close-up observation. So the nails, boom. What about the hands? What about the palms? We talked about Addison disease earlier, didn't we? About the creases, and they've become hyperpigmented. What else can you diagnose in the hands just by looking, or at least have an idea of diagnosis? Any ideas? We had acromegaly earlier as well, didn't we? So some of the endocrine diseases. Any other ones? Okay, if I was to present to your clinic like this, my fingers are pulled in like so, here, what might the diagnosis be for that? Apart from trigger finger, which is surgical. But what else could do that? Any ideas? Have any of you seen this before? Any of you seen this with anybody?
Rheumatic arthritis.
Okay, so that's a good point. So RA patients, they tend to, once they get really severe, they tend to be like this. Their hands are in pronator drift, and they can have boutonniere, or they can have the swan neck deformity. I hope you never ever see that in the future, because there is such good treatment these days. You should never see that, and if you do, it means we as doctors have failed the patients. It is not the patient, it is the doctor's failure. So if you ever see that, the doctors have failed the patient, I'm afraid to say. Sorry, but that's the truth. But this is not usually RA. Okay, you might have a nerve palsy that's doing this, but if you've got thickening of the palm here, of the tendons, this is something called Dupuytren's contracture. Dupuytren's contracture. Can anyone tell me the common causes of Dupuytren's contracture? You may not have even heard of it before, so you would say, well, I've never heard of it. How am I supposed to know what causes it? Yeah. Okay, so common causes are chronic diabetes mellitus. So tonyo-byo, but chronic, not acute onset, chronic. And alcoholic liver disease. The alcohol, which is the poison here. And there are several other causes, including HIV, maybe occupational, and so on. It may be familial, maybe in families. Okay. But we're looking for disease. We're not looking for normal here. So we could say, this patient may have diabetes or maybe a heavy drinker. And we can start to look for other things that are consistent with that. So Dupuytren's contracture is a very nice one. Do you know any other things that might be in the hands? Let me think. What about the color of the palms? What about the color? All right, I want everyone to put their hands up to the screen, please. Put your hands up, right up to the screen. Okay, that's good. Aha. Let me have a look here. Now it may be just the coloring of the environment, but I'm going to say to Ijima-san here, do you like eating lots of fruit and vegetables?
No.
No. Oh dear. I was hoping you said yes.
I think so. So I said no.
It may be so it may be just the color of where you are in the room here, because I can't see you. I can't see your palms close up. But sometimes you can get an orangey yellowish discoloration of palms, and it's called yellow palms. Now, if you've got a very genki oji-chan or ba-chan, usually it's because they're eating very healthily and they have beta carotenemia. So they may be eating lots of carrots and edamame, very genki. And they may be in the hospital for another reason. Or they may be taking supplements. Some people take the beta carotene vitamin supplements. However, if you've got other patients, they may have diabetes. This can produce the beta carotenemic phenotype in the hands and also in the feet. Hypothyroidism, so underactive thyroid, can do the same. Sometimes patients with anorexia nervosa, they can develop this. And also, strangely enough, chronic liver disease, but without jaundice. So no jaundice, but they've got yellow palms and yellow feet. That can occur in liver disease patients. So this sign can be healthy, but it can also be an abnormal sign. So it shortcuts sometimes the diagnosis. So if you had the Dupuytren's contracture and you had yellow palms, you'd say, hang on a second, that occurs in this disease and this disease. Boom, they may have diabetes. put the two signs together. They may be separate diseases, but they may be the same disease. Okay. Do you have any questions at this point? We have 17 minutes left. We haven't got much time. We haven't gone through the rest of the body yet, have we? We're just on the hands. So important.
I have a question.
Jump in. Yeah.
How can we naturally observe the patient's hands, or do we ask them to show their hands?
What I do is this is maybe a difference between cultures. In Western culture, it's very common to shake patients' hands when you meet them. When you greet them, you shake their hands. So hello, Mrs. Jones. Hello, Mr. Whoever. You shake their hands. And you can get a lot of information just by shaking someone's hand. Is it warm? Is it cold? Is it dry? Is it sweaty? And you can tell if somebody is anxious or not just by touching their hand. It's cold and sweaty. Say, they've got anxiety. You can't do that always just by looking. But when you do the examination, say, please show me your hands. Show me your nails. Turn them over. So you ask them to do that as part of the active part of the physical exam.
Okay, thank you.
Yeah, good. Any other questions so far?
I have a comment.
Please jump in.
I did a lot of clinical rotations in England some 20 years ago, and I noticed
Whereabouts?
that there's so Southampton and King's College.
Oh,
so King's
I
College
was
was there for like 11 months total.
Yeah, I used to live near Southampton.
Oh yes.
How long were you in Southampton for?
That was through Japanese Foundation, so it was like a 1-month rotation, but I made friends and went back there. Lovely place.
Did you go down to Bournemouth when you were there?
Yes, for liver retrieval, like for donor surgery, but
that's my hometown.
But oh yes, and I also went to all those islands, Isle of Wight,
Isle of Wight,
Isle of Man, and
I
also traveled all over UK. That's another story.
Wow.
But a month traveling UK. But anyway, I noticed that they put a lot of emphasis on hands and especially nails. And so I was studying for the PLAB for a little bit, and there are a lot of questions in colorful textbooks. And so because of that, I did diagnose a lung cancer patient who presented with fracture just from clubbing. And then so when you mentioned that actually, when I was a medical student, so that kind of made me look good. So yeah, just bragging.
Excellent.
Thanks to England.
Very important. Yeah. Thank you for mentioning. Yeah, very, very important. And that's what I'm trying to teach here. So people look at me like, he's crazy. What's he teaching us about nails for? You can diagnose disease. Any other questions or comments so far? Anything. Doesn't have to be related to what we're talking about at this point in physical. It may be something else. Probably many of you haven't done it yet, or very early in your stages of learning. Anybody?
I make some comment.
Please, yes, of course.
Maybe in the near future, the telemedicine is maybe become big in every country, I think. And in that case, we cannot see the patient face to face, and it's difficult to see this or this.
I agree.
So to overcome that difficulties, do you have some tips or some tools to make a correct diagnosis?
That's a good question. I think that the way of dealing with this is a vaccine. We need a vaccine ASAP. I know that there are many doctors abroad who are now doing telemedicine. They're not seeing patients directly. I understand why. I do understand why, but not everybody's got COVID-19. and you still have to work as a doctor, and part of that is still seeing patients. By all means, doctors should protect themselves as much as possible and wearing personal protective equipment. But I think it should not be that doctors are just putting themselves into isolation and not seeing patients at all. Because I did that. I did that for a few months and I almost went crazy. Seriously. I said, no, I'm not seeing patients at this point. I'm only discussing histories at this point. That was before I knew, what we know now about the virus. In the end, I said, bugger it. I'm going back to the ward. Because for me, particularly, I have to see patients. Not that I'm forced to, I want to, and I want to teach. And my way of teaching is through seeing patients. So I actually went back to the wards with protective equipment on and started to see patients. And it's brilliant. Really, really good to see patients. It's the most rewarding thing, apart from the general teaching, but it's really rewarding seeing patients. So we need a vaccine. That's the first thing. But that's going to take some time into next year. In the meantime, getting adequately taken photographs or video is a replacement, but it's not perfect because there's many things you can't tell just by looking at those. But video or photographs are helpful. As for other things, it's much more difficult. That's what I would suggest. And that's what I asked my colleagues. Have you taken a photograph of it? But please, if you do that, please make sure you get permission from the patient first. Don't just take it. Okay. Say, may I take a photograph or whatever, and then say what it's for. Is it going to be published or just shown internally? Please make sure you get permission before you do it, please.
Just one
Good
suggestion.
question. Yeah.
Right now, I do a lot of telehealth, but we use a Zoom, so at
Yes.
least I can see the patient. And particularly in a nursing home or the other place, there's some nurse, they show, and even I ask her to touch the abdomen.
Okay.
And so not just, audio, but you have a good telemedicine, system. So that can be easily used, I think, yeah.
As long as they've got a good camera.
Yeah.
Like maybe I don't know, a GoPro, something like that it's linked up, that you can get good pictures.
Right.
That can be helpful, I think. Yeah. Does anyone have any other questions or comments about physical exam?
I absolutely agree with what you said earlier of physical exams, how important it is to actually examine the patient, touch the patient, and examine the patient. And as recently I've been more of a patient and patient's family, so advocate more than anything. And so patients do screen doctors based on if they actually perform physical exams or not. And when you actually get the medical records, you see that, like you have all these exams because you have to check the boxes, and they make it look like they did full physical exam, even though they did not lay a single finger on myself. So I think that was a good point. And we actually have screened like neurologists who didn't do any neuro exams at all. And they're neurologists. So they in Hawaii, by the way.
Don't say where. Don't say where. It's a secret.
In the US, yes. So that is very true. So I would like the medical students to never forget that.
Good. And I agree. I mean, the copy paste culture should be abolished, I think. Particularly, you can have these templates and you can just copy paste it and it looks like you've done the physical exam, but actually as you just mentioned, you haven't even laid a hand on them. And I see this quite a lot. But I know when somebody's telling me a porky and they say they've examined the patient, I say, oh, really? Could you tell me about this then? And they may have had some surgical problem in the past, and they may have had an appendectomy. So I say, any scars on the abdomen? Oh, no scars. I say, are you sure? Yeah, okay. And then I say, did you examine this patient? Yeah. With the clothes on? So you didn't examine them correctly then? Because you should always examine the abdomen by looking at the skin, because you may miss scars. And so I know when people have not done the physical exam adequately. I've been doing this for a long, long time, and I've got eagle eyes. So this kind of copy paste thing where they say, I did it, I can tell, and it should really be abolished, and they should be forced to write it out in full, because that means that if they've done it, it means they've done it. Otherwise, it's just Mickey Mouse. Otherwise, you can't tell otherwise. That's just one of my gripes. But thank you. Any other questions or comments before we close? Because we've got 5 minutes left now, before we close this session.
I have a question.
Yes, please.
So I'm in a rotation right now, and then my professor or my
senior
superior is telling me to go see patients, inpatient, maybe like twice a day.
Okay.
And I'm required to do the physical exams. How often should I do? Like, and when is better, morning or afternoons?
It depends on what's wrong with the patient, really. If your patient is stable and they're not changing very much, then I mean, you can do once a day, of course. I mean, that's for training in terms of that. But if you've got a very stable patient, usually just once a week is adequate for a stable patient. Okay. But if you've got somebody who's very unwell, they may require to be examined several times in the day because their condition's changing. Okay. Somebody mentioned before about heart failure. That can change very rapidly sometimes. So they may require a physical exam. Or they may have a history of heart failure and you're giving them fluid for another reason, and they may get fluid overloaded. So repetitive physical examination of the lungs may be helpful when looking at the jugular venous pressure. So it really does depend on what's wrong with the patient, I think. As for morning or evening, again, normally rounding occurs in the morning, so you get all the jobs done, and then you can go back to the sickest of patients in the afternoon and into the evening. So probably I would suggest morning time, and those who are more unwell, you go back again and see in the afternoon, depending upon their condition, their treatment, and so on. It's kind of common sense. I try and teach this principle. It's a common sense. If this was your relative, would it be adequate for just once a day if they were really ill? Of course not. You want to go back and see them again. So it does depend on the patient. Yeah.
Thank you so much.
Thank you, and good luck.
Thank you.
Any other questions, comments? Okay, so I'd just like to make one kind of final comment. 2 hours has just gone very rapidly for me. Sorry if it's bored you at all. Hopefully not. But I hope this has given you a snapshot of how exciting physical examination can be. We haven't covered even maybe 1% of what, even less actually, of what can be done in terms of picking up signs in physical. I've just shown you a very small bit, and from this, we can start to diagnose common diseases that you would normally say, oh, I need to take a blood test for that. Well, of course you will, to confirm it, but to have the idea of the disease existing in the first place, you need to be thinking about it from the history and also from the physical exam. So I hope that we get to meet across at the Shizuoka Medical Center at some point or elsewhere, depends on where you're training. But please take history taking and physical examination seriously. It isn't a joke. It isn't a one-liner and a quick physical before you put them in the CT scanner. If it is, you are shortchanging yourself for your future. Let me tell you, you're shortchanging yourself. If you want to have some pride in what you do as a doctor, it is not how to press the button to the CT scanner. It is not. It is your basic skill that you can do without a machine. Otherwise, you become slave to the machine, in which case you might as well go and jump in the Matrix with Neo. Have you seen the Matrix? Okay.
Maybe too young, I guess.
Yeah,
Okay.
that's like my generation, I think.
My generation too, actually. So this is more homework for you. So number 1, homework. I mentioned earlier on, Moonraker. Okay, it's a bit of an old one, that one. Early 80s, I think, Moonraker.
That, I don't know when it came out. I mean,
1983.
I saw it on VHS.
Yeah, VHS. So I think it was like 1983. I'm not sure about that. I think I was maybe early, maybe 1980. Say 1980. See, that's homework number 1. Then the more later one is in the 1990s, late 90s, wasn't it? Is The Matrix. You need to see this, you guys and girls. You do need to see it.
Moonraker is 1979.
Oh, I was 1 year out.
So I was around.
Yeah, me too. So The Matrix. This is Keanu Reeves. Keanu Reeves. You got to see that. Okay.
Joel, can you add one more from me?
Yes.
That's
please.
1999.
It's a 1962.
Ah,
Do you know
which
what
film
this
was
is?
that? No.
Ben Casey.
Ben Casey.
Maybe you even don't know Ben Casey.
I don't, but I will look that up.
Yeah, Ben Casey is you know the Casey, the white coat with the Casey style.
Ah, I think so. Yes.
Yeah, that's origin from him. Basically, it's a neurosurgeon's story in 1962 when I was 10 years old. That's the main reason. Originally, I want to become the surgeon in the United States.
Oh, I see.
You can see it on the YouTube.
Okay, I'll have a look.
It's a black and white though.
Yeah, it's black and white. I'm just looking at I'm looking at Google right now about it.
Yeah, it starts with a good music and it says birth, death. What is that? Man and women, birth, death, and infinity. Anyway.
Okay, I'll look that up actually. Thank you. Ben Casey.
And by the way, The Matrix, they're releasing a 4th movie next year.
Oh, really?
Yeah.
Okay.
Yeah, you better watch the trilogy to catch up.
and guys, if you're really interested in Keanu Reeves, then I would suggest watch John Wick. Okay, then you'll understand.
What's a John Wick?
You need to see it to understand it.
John Wick.
Something about a dog.
I thought
a dog and a car.
Break or something.
I prefer John Wick myself, actually.
Anyway, so enjoy the movies, but also enjoy taking history and physical. Actually, it's very actually enjoyable process as a physician.
It is.
Because it's just like you can make a diagnosis by HMP many diseases without doing any tests. Yeah.
That's right.
And actually, I think for the student, particularly history and physical, when you become the resident or more like a junior, senior, physician, you don't have much time to spend, doing these things. So when you the student has a lot of time to do thorough physical and history taking. So yeah, you get used to do it. So that's really nice lecture today for
Thank
all
you very
young
much.
students. Yeah, thank you very much.
Thank you for everybody who's participated today.
Yeah.
Thank you very much.
I have one last question for Dr. Branch.
Of course, yes.
So when you said you like to people watch. When you spot a patient, do you actually walk up to them and let them know that there's something wrong with them, or
no?
What do you do about it?
Well, because I might scare the living daylights out of them, and the other thing is I don't want them to feel, because they may realize they've got the disease, and I don't want to make them feel that they're being looked at and that they're abnormal. So I have seen, for example, some actors who've got clearly got ischemic heart disease. They've got the earlobe crease sign. And one time I did write to one of them, but I decided not to in the end because I thought it would be inappropriate to do so. That was an actor who was in a TV program, a Canadian TV program. I forget the name of it now. Oh gosh, I can't think of it off the top of my head. But no, I almost wrote to them, but I didn't in the end. Yeah. It's just, I think it's unethical that I go up to somebody and say, "Hey, you've got that disease," because they might take it badly. Yeah.
Okay. Thank you very much for your time, and hopefully the student enjoy your lecture, and maybe actually I hope each of you meet somewhere in the bedside so that
Me too. Yeah.
Joe can teach directly on the bedside.
Yes.
Okay,
At the
I think
Shizuoka Medical Center. Yeah.
yeah, yeah, Shizuoka Medical Center. If you come, Joe comes, so you can learn together. Okay, thank you very much for your time, and this is the end of this second session. And be safe and healthy, everybody, this time. And hopefully I can see you guys in Japan also.
Looking forward to it. Thank
Okay,
you.
see you. Bye.
Thank you. Take care. Have a good evening. Thank you again.
Bye.
Bye-bye.
Bye.